Welcome to the exam 2 review session. So we are going to jump into the PowerPoint. I did email this PowerPoint out to everybody, so you should have it. And there we go. Okay. So we're going to cover kind of do a brief overview of the material from the weeks that will be on the exam, and so you kind of get an idea of what you should start looking at studying for items this week. So first up is going to be, I believe this is from week 4. So week 4 contains some info on molecular diagnostics, flow cytometry, and then other CBC kind of instrumentation ideas. I should have removed the chapter numbers here. I'm sorry. These chapter numbers are the old ones. Ignore them. I forgot to remove them. But at any rate, molecular diagnostics, there wasn't a lot to know from this specific PowerPoint. Basically, just kind of why do we perform molecular, especially in hematology. One of the main areas is that they're looking for different chromosomal translocations that kind of result in forming various leukemias or other diseases. They're just used mainly in regards to diagnosing hematologically significant diseases. And then finally, they can help monitor that disease after cancer treatment. So those are the main areas and purposes of using molecular diagnostics for hematology. Flow cytometry, this is a subsection of hematology. It's kind of a specialized area. Not everybody gets to work in there. You have to have kind of specialized training to go through it, but the great thing is you guys can definitely get that sometime when you go into your careers. So flow cytometry is an analyzer that will look at helping diagnose malignancy by looking at not only what types of cells are involved by measuring scatter, but also what surface markers are present on those cells. So first, this is the one that the cells have to line up one by one and pass by this light source. And then based on the scatter, they can kind of determine what type of cell it was. So again, forward scatter is going to tell us the size of the overall cell, and side scatter is going to tell us the complexity or granularity of that cell. And then on that surface, they're also looking at different surface markers, or what we call CD markers. Lots and lots of CD markers exist, but we kind of whittled it down to just some key ones to know. Letter A there, anything less than 10 typically is a T cell. That's what I kind of memorized. So 2, 3, 4, 5, 6, 8, all T cells. The CD marker 10, we can also name that CALA. If you ever hear that reference, CALA, that's just referring to CD10. CD19 and CD20 are all B cell markers. TDT, that is kind of it's a very immature cell belonging somewhere in the lymphocyte area. So it's either B or a T cell, but it's an immature lymphocyte marker. CD14 was monocytes. CD13 and a lot of the 30s tend to belong to the granulocytes. CD34 and 45 are very immature cells, and CD61 are going to be megakaryocytes. Make sure you go back and look at the PowerPoint or listen to lecture. Make sure you have these CD markers kind of memorized for you. And then that third PowerPoint in week 4, CBC instrumentation, we learned how electronic impedance was used in analyzers to help count and determine the types of cells present. So as these cells pass through an aperture, there's electrodes on either side of this aperture that creates an electrical interference. And then as the cells go through that, it will cause that electrical interference, kind of like a pulse. And we'll count the number of pulses will equal the number of cells, and then the size of the pulse will equal the size of the cell. And so they put all that information together to determine cell counts. Week 5, we had 2 PowerPoints. One was myeloproliferative, listed here. There were 4 diseases in myeloproliferative. Again, to be considered myeloproliferative, it means that that disease is somehow overly producing or overaccumulating one of the cell lines, or it could be all of the cell lines. But at least the red cells, one of the white cells, or the platelet line is being overly produced. So the first disease was chronic myeloid leukemia, CML. It's named that because it really heavily affects the myelocytic side of the stem cell chart, which is red cells, granulocytes, and platelets. So you're going to see lots of neutrophils in all different stages. So you're going to see myelocytes, metamyelocytes, lots of bands. You'll definitely see huge increase in basophils and eosinophils as well. Those are also granulocytes. The chromosome that was key in diagnosing CML, remember, is the Philadelphia chromosome, which is a translocation of chromosomes 9 and 22. So keep that in mind. That's a very diagnostic marker for CML. Overall, CML has a really high white count. A lot of times it's above 50, around 100. If you were to do that LAP stain, you would see a decreased LAP score. And then again, at any point, it can change into an acute leukemia, or what we call blast crisis. So chronic leukemias have very few blast cells. They have lots of other types of immature cells, but not as immature as a blast. Acute, remember, have blast cells present. So we know when a CML is turning into acute leukemia when we start to see the blast cells show up. Next disease was polycythemia vera. This is just basically an overproduction of everything. So I always just say everything is increased. If you jump down to the last bullet there, it says that everything is increased. We have increased hemoglobin, increased hematocrit, because there is increased red cell count. And so if you have lots of red cells, you're going to have lots of hemoglobin and lots of hematocrit, packed cell volume. You will also see increased white cells, increased platelet count, so kind of pancytosis, or if you look at it in the bone marrow, it would be called panmyelosis. All cell lines increase in production. With that being said, the LAP stain is also increased. So you kind of get this gist, everything's up. The cells itself, those red cells, are still normal in size. They're still normochromic, normocytic, normochromic. And again, the only thing that wasn't increased that I kind of made sure to point out in the lecture PowerPoint was the sensitivity to erythropoietin. Erythropoietin is a normal level. We're just extra sensitive to its effects. So our red cells are really producing, it's really sensitive to the effects of that hormone. But the erythropoietin hormone itself, it stays at a normal level. But all the cell lines are increased. Essential thrombocythemia, as the name implies, all about the platelet lines. So we're going to definitely see increased megakaryopoiesis. You can even see a megakaryocyte kind of show up in the blood smear. Key is going to be the number of platelets. It's not just slightly increased, it's greatly, markedly increased. So greater than 1,000 a lot of times platelet counts. And then with that, the platelets don't function very well. So it's poor platelet function. So they're still prone to bleeding disorders or even maybe some abnormal clotting forming because of so many platelets happening. So it just kind of ties in together there. So that's the key. And if you get a case study, looking at that huge, huge platelet count of that, and then knowing that nothing else is really affected, it's just the platelet line that's affected here. And then our fourth disease here was called myelofibrosis. You can know it as the full name MMM or the CIMF. Either one, both of them state myelofibrosis in their name. So if you just know it as myelofibrosis, that should work. The problem with myelofibrosis is there's definitely an ineffective hematopoiesis. They're not making cells well. And this is the one that, oddly enough, they start making cells in the liver and spleen as well. Not sure why it happens, but it does. All of a sudden, their liver will start producing cells. So you get a very hypercellular bone marrow. They're trying their best to produce cells. It's not growing great. The cells that we do get are kind of weird. So we're going to see some immature granulocytes, so metamyelocytes, bands showing up. You'll also see those nucleated red blood cells, so immature red blood cells showing up. Remember, that is a term with both the immature granulocytes and the nucleated red cells. That is what we would call leukoerythroblastic, because we have both the immature grands and red cells showing up. With the red cells, the shapes get to be really weird. There's a lot of poikilocytes going on, especially teardrops, what we call dacryocytes. This one also can see megakaryocytes show up in the peripheral blood. Very unusual to see that. And then the key to diagnosing this is staining the bone marrow and seeing that increased fibrosis present. And then the other chapter that was in week 5 was myelodysplastic syndromes. The two big characterizations of myelodysplastic is you're going to have a cytopenia, meaning at least one cell line is decreased, and you're having dyspoiesis, meaning the cells that are present are not made well. They're abnormal in their look, and a lot of times they're abnormal in their function then as well. This all results back to abnormal stem cells. So if you get an abnormal stem cell, you're not going to make any healthy cells really. Any one of these myelodysplastic can convert to being an acute leukemia. So different thoughts on what might be causing it. Nothing is pinpointed for sure, but lots of this have been linked to it causing myelodysplastic. So let's go to some of the changes, the dyspoesis changes that you might see in the cell lines. In the erythrocyte line, the dyserythropoiesis, you're going to get oval macrocytes. So we will see microcytic hypochromic red cells and those oval macrocytes leading to what we call a dimorphic red cell population. In the bone marrow, if you were to stain that with Prussian blue stain, you would also see ringed sideroblasts. Some of the myelodysplastic have more than others on that. Dysgranulopoiesis, so for the granulocytes, you get persistence of basophilia in the cytoplasm, meaning they keep that dark blue coloring even as they get older. Abnormal granulation, abnormal nucleus shapes, and then just uneven staining. All right, so there is your myelodysplastic classifications. We have refractory anemia with ringed sideroblasts, CMML, and then there's a couple others I didn't fully list. Make sure you go back to the original PowerPoint and look at those. Remember, we're just having to know the FAB ones. I know that WHO has a whole different classification for myelodysplastic. We're just remembering the FAB classification. So make sure you go back and look at that. You also filled it out on a study guide. Again, all of these can convert to an acute leukemia. We will know it's an acute leukemia. According to FAB, it has to be greater than 30% blast. According to WHO, it only has to be greater than 8% blast to be considered acute. All right, and then going into acute leukemias, which was week 6, we did leukemias and lymphomas. Prognosis of acute leukemias just all depends on the age of the patient, the chromosome translocation that is involved. We, again, learned the FAB classification, and remember, FAB always classifies according to morphology. So there is ALL and then AML for acute leukemias. ALL is acute lymphocytic leukemia, meaning it's going to be involving the lymphocyte lines. So symptoms-wise, they share very similar symptoms with the acute leukemias. They both kind of have splenomegaly, hepatomegaly, leukocytosis, neutropenia, thrombocytopenia, anemia, and then with ALL, especially bone pain, because ALL is the one that's typically found in children, 2 to 10-year-olds. And so we do get that complaints of bone pain. But you can see bone pain with some of the other leukemias as well. So CD markers are always great here. Stains are always great to know what is going on. For CD markers, remember, they will point to if it's a T cell ALL or a B cell ALL. So CD10, CD19, CD20 are all B cells. Remember, CALA is that other name for CD10. That is an immature type B cell. And then TDT is always a great one because that tells us both B and T cells. It's just an immature marker for either one. T cells would have anything less than 10 for a CD marker found. And then AML was the majority of the rest of the acute leukemias. And we have the M numbers there. You got to know each M number with each leukemia. If you kind of try to know their names, it will help hopefully point out what's involved, what key cells are involved. Overall, again, same type of symptoms, anemia, thrombocytopenia, neutropenia, bone pain, all that, leukocytosis, you know, all that kind of stuff. So let's start with M0. M0, again, is AML minimally differentiated. This basically means that it's almost all blast cells, so it's like greater than 90% blast cells, and they're extremely young blast cells. They are so young that they've just started to become a blast cell. As a result, they do not stain, and they won't have our rods present yet. So none of that will really work with M0 because they're just really, really young. M1 is AML without maturation, so we still see a ton of blasts, still above a 90%, but now they're kind of become their blast cell stage, so they will stain positive with myeloperoxidase and Sudan black B. You will also see our rods present in the cytoplasm. M2 is AML with maturation. So now we're getting lots of blast cells still, but we're now starting to see some promyelocytes, maybe myelocytes show up. So we get a few other things showing up here. We still have our rods. We're still going to see positive myeloperoxidase and Sudan black B showing up. M3, acute promyelocytic leukemia. As the name tells you, it's all about promyelocytes. Lots and lots and lots of promyelocytes being seen. This one did have a chromosome translocation to remember. So it's the chromosome translocation between 15 and 17. With those promyelocytes, they're going to be very hypergranular. They will definitely have our rods. Some of them have many our rods. That's that whole Faggot cell term that comes up. M3 is also heavily associated with forming DIC. M4 is acute myelomonocytic leukemia, so we're now seeing both kind of representation, both the myeloid or myeloblasts and now monoblasts also being seen. So an increase in the monocytic cells that are present. So the non-specific and specific esteries would work really well. M5 is acute monoblastic, greater than 8%, or monocytic smear, and so non-specific esterases are positive here. M6 is our erythroid. We have two forms. Acute erythroid leukemia contains mostly pronormoblasts and some myeloblasts. Pure erythroid leukemia contains all types of only the immature pronormoblasts and basophilic normoblasts in the red cell line. So no myeloblasts in the pure one. So again, PAS stain will stain positive for this M6. And then M7, acute megakaryocytic leukemia, it's probably the rarest of all of them, and again, it's involving the megakaryocytes, so lots of megakaryocytes in the bone marrow. So we've hit every cell line now for acute leukemia. You just have to remember the name, and hopefully if you have a CD marker that goes in, you do fine. And then the last chapter, 86, was on lymphomas. So lymphomas, again, are different because they occur in the lymphoid system, where leukemias occur in the bone marrow. So lots of different thoughts on why lymphoma occurs, kind of same thought processes, why leukemias do, maybe it's a viral, chemical exposure, altered immune function, whatever. So we didn't really go heavily talk through this, but I think your lab review questions would have had this on there, multiple myeloma. Multiple myeloma maybe was learned also in immunology if you've already had that. If not, you'll probably see it there at some point. But multiple myeloma is tons and tons and tons of plasma cells. So you're going to see sheets of plasma cells in the bone marrow, and they will spill over into the blood. And they're basically, remember, plasma cells make your antibodies. And so in multiple myeloma, though, we are going to see abnormally producing weird antibodies. They're not going to produce like the nice full normal antibody. They tend to produce just like a light chain of the antibody. That would make sense to you if you've been through immunology. If not, don't worry about it yet. But just know with multiple myeloma, lots and lots and lots of plasma cells involved. You'll see bone pain with this, very anemic, they'll be very anemic, and then kidney failure. Those are kind of the triad of signs that go with multiple myeloma is bone pain, severe anemia, and kidney failure. All right, otherwise, we did classify our lymphomas into whether they are B-cell based or T-cell based. So the first one in the B-cell is CLL, or you can call it SLL. So lots and lots of small lymphocytes. In fact, when you do that count, and I know at least one or two people did that count last week, I saw in their lab report, but you'll count like 80 to 90% lymphocytes. It's kind of fun in a way. But you also get these smudge cells, and that's the picture. I had this picture also in an announcement. Smudge cells are basically these lymphocytes that are pretty fragile. When they go to make the smear, to look at it under the microscope, it smudges them out because they're fragile lymphocytes. So you get what you see there. Those are pretty diagnostic for CLL. Hairy cell leukemia is a chronic B-cell leukemia. You get hairy cytoplasmic kind of protrusions from the lymphocytes, which is why we call it hairy cell. And again, the key stain to diagnosing that is TRAP. Mantle cell lymphoma, there's not a lot to know on this one. It's more medium-sized lymphocytes, but very severe lymphoma, only about a 3 to 5 year survival. And then finally, or not finally, next is Burkitt lymphoma, a bit more on this one to know. Burkitt also has medium-sized lymphoid cells, but these are kind of unique in that they'll have very much a very dark basophilic blue cytoplasm, and they'll tend to be vacuolated cytoplasm. In the bone marrow, they have that starry sky pattern that we discussed in the lymphoma chapter. Hallmark sign is a high proliferation rate, the ability to just keep making and making and making more of itself. Very much linked with after having Epstein-Barr virus. And then our last B cell is Hodgkin lymphoma, typically younger patients like teenagers. And then the diagnostic cell in Hodgkin's, again, is Reed-Sternberg cells, which is a large lymphocyte that has 2 nuclei. Under the T cell, there's just one Sézary syndrome. Sézary syndrome has what we call lymphoma or Sézary cells involved. Those are the ones that have that clustered nuclei, so they have kind of that break down the center of their nuclei, and you might see those. There also with Sézary syndrome, you see a lot of skin kind of infection or disease happening as well. 5-year survival rate with this one. All right, so that was kind of a whirlwind review of weeks 4 through 6. Make sure you still go back to your original PowerPoints, look through everything. You can re-listen to the recordings. I always try to point out when there are things that I think are important or try to expand or explain on things. I know in these reviews that I go kind of quickly through it, but the idea is just to be like, oh yeah, that we did learn that in that week, and give you a heads up of I need to look at that for the exam. And then you can go back and study it a bit more from the actual lecture and PowerPoint. So that's kind of the idea, is just to do a broad overview, get you thinking about, yep, this is what's going to be on the test. I need to go back and restudy these. Relook at your lab review questions. Those are always a great thing to know as well. As always, if you guys ever have questions, please feel free to reach out. Otherwise, I wish you best of luck, and thanks.